How you doing? This is Dr. Zafran, and we're going to continue our discussion on cardiac output in conjunction with our fundamentals and understanding of cardiac physiology. Here on the board, we have some core concepts that we're going to be discussing throughout this lecture. We're going to be talking about the controlling variables of cardiac output. So what is cardiac output? Cardiac output is comprised of two different variables, stroke volume and heart rate. We'll discuss what stroke volume is, and we'll discuss how stroke volume and heart rate contribute to cardiac output. We're going to be talking about resting versus exercising cardiac output, how our body changes physiologically, particularly in terms of cardiac output, are going to be dependent upon whether we're at the resting state or whether we're in an exercising state. Even within the exercising state, we can look at things in terms of early exercising and late exercising. As you can see from our diagrams here, or from our equations, we have cardiac output as a function of heart rate times stroke volume, cardiac output as a function of heart rate times end diastolic volume minus end systolic volume. So what we can see here is that end diastolic volume minus end systolic volume is equal to stroke volume. So we've been able to extrapolate that here. So what's a good example of cardiac output as measured in a human healthy person? We're not looking at cows today, we're actually looking at humans. So in a healthy person, with a heart rate of around 70 beats per minute and a stroke volume of 70 milliliters, if you multiply those two together, what you'll find is 4,900 milliliters per minute. But when we're looking at cardiac output is measured in liters per minute. So we actually have a value of approximately 5 liters per minute as in terms of our cardiac output. We're also going to look at mean arterial pressures, which is our cardiac output times systemic vascular resistance plus CVP, which is our central venous pressure. Mean arterial pressure can also be understood as 2/3 of your diastolic blood pressure plus 1/3 of your systolic blood pressure. Now we're going through these different concepts and these different ideas in a grand scale to understand what we're going to be talking about. We'll try to bring in a clinical application. I'm an anesthesiologist by trade, so every day when I'm in the operating room, I try to pull in different physiology concepts and bring in clinical applications so that we can understand the fundamentals in a better way. Okay? All right, so let's talk a little bit about our end diastolic volume. An end diastolic volume gives us an understanding of our preload. So what's our preload? There's all these different kind of terms. The preload is basically an understanding of how much blood that we have at the end diastolic, when the heart is relaxing, how much blood is actually emptying into the left ventricle or the ventricles. Okay? Preload is one parameter that affects our stroke volume. Okay? What are those parameters? Number one, we have preload, which we just discussed. Number two, we have contractility. Contractility is the ability of the heart muscle to be able to contract, which enables blood to eject from the ventricles through the aorta and into the systemic the systemic circulation. Okay? And the third we have is afterload. Now here we have a diagram of systemic vascular resistance, also known as afterload, and that's directly correlated with our mean arterial pressure, our MAP. We heard about that a little bit before. We know that our mean arterial pressure is 2/3 of our diastolic pressure plus 1/3 of our systolic blood pressure. Okay? All of these three factors are going to influence our stroke volume. Okay? And our stroke volume being one of the primary determinants, right, in addition to heart rate, of our cardiac output. So what does all this mean? When somebody is sitting at rest, okay, and we're talking about what our resting cardiac output is, what we're looking at is a function of our heart rate, right? Resting heart rate can be anywhere from 60 beats per minute to 80 beats per minute, or even up to 100 beats per minute. When you get above 100 beats per minute, that's what we call tachycardia, okay? But in a normal cardiac person, in normal blood pressure, a normal heart rate, their heart rate will be anywhere from 60 to 100 beats per minute. Okay? When you put that in conjunction with your stroke volume, that is influenced by your preload, your end diastolic volume, your afterload, which is your systemic vascular resistance, and your contractility, the ability of the heart muscle to contract, getting the blood supply to the systemic circulation, you have these parameters that contribute to your cardiac output. So for example, let's say you have somebody who's an Olympic runner. Their cardiac output is going to be different than the cardiac output of a person sitting at home watching television. What's going to change? Well, a few things change. In early exercise, what you find is that cardiac output is primarily determined both by heart rate and by stroke volume. Okay? Each contribute equally to increase your cardiac output. When you get to a point where you're a marathon runner and you've been exercising for a certain amount of time, the variables change up a little bit. You become more dependent upon the heart rate, because as you run, your heart rate increases, and less so much on your stroke volume. Your stroke volume, because of the ability of the heart to contract, gets limited, and the stroke volume plateaus. Okay, that's one aspect of how cardiac output is differentiated and distinguished between the resting person and the person who is exercising. Interestingly enough, how the blood flow, how that cardiac output is distributed in an exercising person is very different also than a person who's sitting at rest. What do I mean by that? The cardiac output that is being delivered in a person who's engaging in exercise, it wouldn't make sense for all that blood flow to go to places that aren't being needed or necessitated at that time. Your sympathetic nervous system is ramped up, right? So all of that blood flow, or the majority of it, 60 to 75% of it, actually gets diverted to the muscles, to the skeletal muscle system, so that it can utilize the blood, the nutrients, so that you can continue to run and have the necessary perfusion and oxygenation and all of those things to supply your tissues in the most efficient way. That gets diverted from what? It gets diverted from your kidneys, it gets diverted from your skin, it gets diverted from your gut. You definitely don't want to be having a stomach ache while you're running. You want to be focusing on getting to where you need to be. Okay? So that's a good example of how cardiac output is distributed to different organ systems, such as the skeletal system in an exercising patient, versus somebody who's sitting at rest, where actually, interestingly enough, at rest, what do you think the majority of your blood flow, the majority of your cardiac output is being diverted to in the resting state? GIT. It's actually, yes, the GIT, but primarily the liver. 21% of the blood flow goes towards the liver at the resting state, as opposed to 60 to 75% of blood flow going towards skeletal muscle in an exercising patient. So we understand the parameters. We know that heart rate and stroke volume contribute to cardiac output. We understand that stroke volume is defined by three components: contractility, preload, which is defined or correlated to your end diastolic volume, and afterload, which is correlated to your mean arterial pressures and your systemic vascular resistance. Okay, so if we want to take the conversation to the next step, what is our pulse pressure? So we've been talking about systole and diastole. Our pulse pressure is a function of systolic pressure minus your diastolic pressure. So when you go to the doctor, you say, what's your blood? The doctor tells you your blood pressure in a healthy person is approximately 120 over 80. So what we see here is our systolic blood pressure of 120 millimeters of mercury minus 80, which is our diastolic pressure. If you take these two and you subtract one from the other, with pathology. What if we are dealing with people not dealing in a vacuum, someone who's not healthy, somebody who may have acute coronary syndrome, atherosclerotic disease. Sometimes patients have valvular disease like aortic stenosis, aortic regurgitation. Sometimes patients are born with anomalies, congenital anomalies like patent ductus arteriosus. How does that affect our pulse pressure? So if we look at what the normal pulse pressure is, here you have your systolic blood pressure, which in a normal person would be 120 millimeters of mercury, and here 80 millimeters of mercury. And your pulse pressure is the difference between those two. But let's think about the example of somebody who has arteriosclerosis. Patient is 80 years old, has a history of acute coronary syndrome, maybe had a heart attack in the past, but their vessels are actually atherosclerosed. So let's understand a main concept here. When you think about pulse pressure, think of this as an action item, as an important point to put in your tool bank. You want to remember that pulse pressure is indirectly correlated to compliance. Okay? By compliance, we're talking about the ability of certain vessels to expand and have what we say, not elasticity, but the ability to have some maneuverability into accept blood flow and so forth. Okay? So let's talk about the example of atherosclerosis. Compared to the normal, is our pulse pressure increased or decreased? When we look at atherosclerosis, is our pulse pressure increased or decreased? When we look at our graph, or our graph here, and you look at the y-axis being our pressure in millimeters of mercury, you can see that in arteriosclerosis, your pulse pressure is in fact increased. Why? Well, the main thing that you want to think about is compliance. Your vessels are now fixed. They're not able to allow blood flow as effectively as in healthy vasculature, and because of that narrowing of the vessels, your pulse pressure your compliance is decreasing, meaning that your pulse pressure is increasing. What's another example of this? Or what's another example of how your pulse pressure can change? If you have a patient who has, for instance, aortic regurgitation, right? Looking at it compared to the normal, you'll see that the pulse pressure is in fact increased. So if you want to think about it in your mind, well, if my pulse pressure is increased, what's happening with my compliance? They're inversely related. So decrease in compliance means an increase in your pulse pressure. So when you have aortic regurgitation, the blood flow that's normally going into your systemic circulation, because of a leaky valve, the last valve that the blood sees before going into the systemic circulation is faulty and leaky. What you're finding is that blood flow is coming back into the left ventricle, giving this aortic valve or the aortic pressure an increase in pressure. It's seeing an increase in pressure when it normally would be seeing a decrease in pressure. As such, that systolic pressure is increased, and now you have an increase in your pulse pressure. Now, this is just an introduction to cardiac output and how cardiac output, what parameters are utilized to determine cardiac output. What I want you to do is go back and look at these equations. Try different modalities. Try to look at them from different vantage points. Try to understand the concepts that affect stroke volume. We've mentioned this repeatedly. Contractility. What kind of things can increase contractility? What kind of vasoactive substances can we use to increase contractility? Well, epinephrine, norepinephrine, dopamine. These are all type of medications endogenously and exogenously that we can give to patients that will increase contractility of the heart, thereby increasing your stroke volume. Well, what kind of things can we use to decrease contractility in a clinical setting? We can use medications like beta blockers that will decrease contractility of the heart, even slow the heart rate down, thereby decreasing cardiac output. We can also use medications like calcium channel blockers that will decrease contractility. Okay? What kind of medications can we use to affect preload? Remember we talked about preload and the ability of the heart to fill, the ventricles to fill the end diastolic volume. There's a medication that we use intraoperatively all the time. It's called hydralazine. And hydralazine is a vasoplegic medication that will decrease blood pressure, okay, by decreasing preload. All of these factors will affect ultimately our cardiac output, okay? And from afterload, remember, afterload is our mean arterial pressure or our systemic vascular resistance. What kind of medications can we give to increase our blood pressure, right? There are medications like phenylephrine that directly vasoconstrict blood vessels. There are medications like we mentioned, like epinephrine, norepinephrine, things that our body endogenously also creates, right? From our adrenal medulla being epinephrine, are catecholamines, the type of hormones and peptides and chemicals that our body naturally releases to help us deal with our flight or fight response. So take some time to take a look at these concepts with cardiac output. Take a moment to look at the parameters that we discussed, including heart rate, stroke volume, end diastolic volume, end systolic volume, afterload, preload, contractility. All of these pieces come together to create a puzzle, and when you put all of those pieces together, you'll have a better understanding of cardiac physiology and, in particular, cardiac output. Thank you.